Okay, so good morning, everybody. It is a real honor to be invited to speak today. As you heard, Dr. Fingerette was not only my mentor during actually an externship that I did from SUNY, but also was my residency supervisor together with Dr. Evan Canelos at the VA. And he continues to be a very important mentor for me throughout my career at this point. I am an optometrist at the Columbia Department of Ophthalmology. I do a lot of work in the glaucoma division and then also just primary care stuff. So today, what I wanted to talk about is what not to do. And I don't want this to be a eccentric, a very complicated type lecture. I think that there's a lot of hesitancy when it comes to gonioscopy and people are afraid to do it. I kind of want to break it down into bare bones and talk about it clinically. It's an amazing tool. Interestingly, my second talk is going to be on telemedicine, and this is something that we all have to think about: is what sets our slit lamp exam, our fundus exam, our everything in the office, what sets it apart from a telemedicine exam. And as we think about redefining our glaucoma care for patients, if we don't know what we're supposed to be looking for on a gonioscopy exam, this is going to be a tough question to answer. So I'm going to go ahead and move forward. No financial disclosures. These are my mentors throughout the year from SUNY. Wanted to say thank you also to Dr. Madonna, Dr. Dool, who I did my ODMS program with and presented my first paper at ARVO. Okay, so I'm going to start with just mentioning a few cases, and we'll revisit these at the end. But this is real time. So you come into clinic tomorrow morning, Monday morning, and in room number 1, you have 45-year-old male. His chief complaint is blurry vision, painful eye, and you check his pressure. It's 50 in the right, 12 in the left. And the question is, what do you do next? Case number 2, you have a 60-year-old male, complains of difficulty with fine print. So in other words, he doesn't have any urgent complaints. His vision is 20/30, and you check his pressure and it's 42 and 48 without any symptoms. What do you do next? Case number 3, and this is the next room over. You have a 35-year-old male, chief complaint, I think my prescription has changed. He's a high myope, 20/20, not seeing any flashes and floaters. You check his pressure at 16 and 19, and he tells you that his paternal grandfather has glaucoma. So what do you do next? Last case, you have a 26-year-old Asian female, chief complaint. She has a new floater in the left eye for 3 weeks, no flashes, no vision changes, and her refractive error is plus 550, best corrected vision 20/20, IOP of 10. What do you do next? So, I'm sure that this group is thinking about different possibilities that they would do with these patients. It's not anything that's, these aren't out of the box type patients. These are pretty bread and butter things that we deal with on a daily basis. So there's different approaches, and gonioscopy is going to be an important component, obviously. So I want to break this down into 3 components of this lecture. The first is the gonioscopy technique. The second is how we diagnose primary angle closure. And the second is dealing with the secondary glaucomas. Gonioscopy technique. For the purpose of this lecture, I'm really only discussing using a 4-mirror lens. The 3-mirror is something that's great that you learn in school, and I think retina folks like to use it in the glaucoma clinic. At least in our glaucoma clinic, it almost has no place because the 4-mirror is easy, it's lightweight, it's easy to be cleaned, it doesn't cause the patient a lot of discomfort. And in terms of sequencing in an exam, if you have that patient going to do imaging or whatever after you do gonioscopy, using that thick lubrication with the 3-mirror is not very realistic to be getting a good imaging result. So the gonioscopy technique is the 4-mirror. We learned that it's a total internal reflection, and I don't want to go into all the optics of that. I think the important thing is to remember that the reason why you can't see ciliary body, you can't see the different angles, the different angle structures in your slit lamp exam is because of total internal reflection. And only after you put that gonioscopy lens and the optics goes ahead and does its work, you can actually see those structures. It's not magic, it's just optics. So this is the Zeiss style 4-mirror lens I'm talking about. And there's a Posner and Sussman version. We use the Posner. Again, it's very lightweight. It takes a little bit of a learning curve and some time to use it and practice, but once you start using it and becoming comfortable with it, there's really no reason to be using more aggressive measures of doing gonioscopy, especially if you're doing it very, very frequently. So this is the one that I would suggest if you start doing it more frequently to start getting used to the Posner Zeiss lens. Difficult eye suggestions. So this is something that I've spoken to a number of glaucoma specialists about. There are always those difficult patients, okay? Even gonioscopy, even when you get comfortable with it, it's obviously a difficult technique to measure, but there's always, even for the experts, there's always going to be deficient patients with very small eye with blepharospasm. And you want to take the extra time to get those patients comfortable. So you don't want them slouching. You want them sitting comfortably at the slit lamp. You want to make it as easy for yourself as possible and to make them also comfortable with what you're about to do. You have to have a certain level of just go ahead and do it. Don't talk about it so much beforehand with the patient. Just let them know, I'm going to be bringing this close to your eye. You're going to feel me go onto your underneath your eyelashes. I'm going to hold up your eyelids and just, kind of talk them through while you're doing it. You also want to make sure that you're very comfortable. So you can rest your arm. You can put a little, the box that holds your lenses underneath your arm, or a book or something like that. But those things can definitely be helpful. Another thing that is so, so important, especially if you have a big blinker or someone who's very nervous, take an extra second and apply another drop of anesthetic to the patient, and make sure that your gonio lens has anesthetic sitting in it, so that when you put it on, they're just blinking because something's going in their eye, not because they feel anything. And then additionally, you don't want eyelashes, right? So if you finally get the lens on the eye and all of a sudden you see eyelashes, you don't want to give that patient a corneal abrasion. Take a second, pull off, open their eyelid a little bit better, and go ahead and get on. And then you don't want to see indentation lines. If you see those corneal indentation lines, then it means that you're pushing too hard. This is something that we definitely learn way back in whatever it is, second year, third year, when you're learning gonioscopy. You always look at the inferior angle first. It gives you a good indication about what's going on, and you can kind of see the structures better that way, and then go ahead and look up. You want to indent. We'll talk about that doing dynamic gonioscopy to get a better feel for what's going on in the angle. And if all else fails and you really cannot do gonioscopy, then just get an anterior seg OCT, or if you have a UBM. Now, mentorship is particularly important. This clip happened last week. I wanted to share. These are my boys. Mm-hmm. So those are my boys practicing their different things. And what struck me with, I was looking at that, and even though it's a cute clip that I like to share, mentorship is just extremely important when you're doing gonioscopy, because you don't know what you're looking for all the time. And if you have somebody that you can bounce ideas off of or learn from, that's also a great resource. So if there's any students in the room, definitely take advantage of that. And then if there's any other doctors in your practices, take advantage of that, or Facebook groups, just talk it over with different people. So now getting into what gonioscopy we're looking for. We're looking really for two things. We're looking for angle closure, and then we're looking to see if there's a secondary process causing that angle closure. So in primary angle closure, you talk about iridotrabecular contact, talk about plateau iris, and in a secondary process, you're dealing with unilateral and asymmetric glaucomas. What you don't want to do is you don't want to say, everything's fine, dilate the patient. You don't want to say this patient has glaucoma, it's primary open angle glaucoma, without realizing that something else is going on. This is where mixed mechanism glaucoma is becoming a really frequent topic discussed. So just to get some of these definitions down, primary angle closure glaucoma is glaucomatous optic neuropathy from primary angle closure. Primary angle closure suspect is where half the outflow channels appear to be obstructed. So you've heard you can dilate a patient who's 180 degrees closed, but that's kind of also in a gray zone. And then primary angle closure is an intermediate stage where there's some obstruction, but vision is normal. Now it's for different people to determine whether at which stage you actually do a laser iridotomy, and we can talk about that in a minute too. These are the questions you want to consider when you are dealing with a narrow angle patient. So number one, is the angle narrow? Number two, what is the mechanism that is causing that angle to be narrow? Number 3, what's the likelihood of an attack? Number 4, what is a proper follow-up sequence and management? This is, in all the cases that I talked about, this is kind of the thought process that goes through any patient that comes in with any of those complaints. So let's talk about the normal angle structures. This is not new for anybody here. And this is obviously pretty obvious angle here. So you can see clearly the ciliary body band, then you can see anterior to that, the scleral spur, and then you see the two different areas of the pigmented trabecular meshwork and the non-pigmented trabecular meshwork, and then Schwalbe's line you don't really see clinically. Here's another depiction of that in more real time. So you can see, the structures over here, the iris root, ciliary body, scleral spur, posterior TM, anterior TM, and Schwalbe's line. I actually have a picture of this on my phone. And for the first, 100 or so patients that I was doing gonio on, I would compare this pretty frequently during my exam, after my exam, just to really make sure that I knew what I was looking at, and before I would grade that angle. And I know that the residents that we work with and the fellows, they frequently will have a picture of something on their phone that they look at pretty frequently early on in their training. This is how we document our gonio. We talk about the grade. This is kind of the SPAIT classification, but also a modified version of it. So you have the grade, you have the approach of the iris, you have the insertion of the iris, you have the pigmentation level, and pigmentation means both grading of the pigmentation, so how much pigmentation is there, and whether that pigmentation is uniform or splotchy. Just talking about grade for a second, when you look at a graded angle, so you think open to ciliary body, grade 4, no problem. It's not just open to CB 360 OU, right? So you can have a very narrow looking angle, and you can kind of tilt that gonio lens and look over the hump of the iris. You can see that it's open to ciliary body, but you wouldn't necessarily call that patient a grade 4 open ciliary body, no problem. So it's not just about open to CB, it's really taking all these different things into account. And the approach comes in very important, especially when you're trying to determine if it's a convex iris, if it's a concave iris. Those have different implications of different secondary types of glaucoma that you have to be thinking about. And then the insertion of the iris, that comes into play with different anomalies that you run into, but also plateau iris, things like that. Okay, other depiction of what we'll talk about with a wide open angle. They throw around this number 45 degrees and a 20-degree narrow angle. This doesn't really have a lot of clinical relevance for people, but I wanted to show it just to get a sense of what we're dealing with the grading. It's hard to really judge 20 degrees from 15 degrees and 10 degrees clinically. This is the Schaefer classification. Something important, if you have a specific grading system that you like, then just do that and stick with it, but recognize that these are the different things that you're trying to look at, all the things that I had outlined in the earlier slide in terms of the approach and iris insertion. And so these things, I found, at least when I was learning gonioscopy, this was a little bit more difficult to relate to, but something important to study and have in the back of your mind. And again, so this helps me a little bit more too, just when you're thinking about a grade 4 is wide open, a grade 3 is wide open, grade 2, you might see ciliary body, even though it says on this you won't, but you could see ciliary body in a grade 2 type angle, but it's still a little narrow. You don't want to just necessarily dilate everybody at every visit if they have a little bit of a narrowing angle, and then obviously you get the super narrow angles. You also don't want to be a cowboy here. So if you think that somebody has a narrow angle and they're not having any symptoms in the posterior pole, and you want a second check, or you want to bring them back, or you want to get a second opinion, there's not usually a rush to dilate these patients, except the cases like we discussed, like I mentioned in the beginning of the lecture. And then this is always an easy way to start your gonioscopy technique, is you want to do a Van Herrick. This is an extreme example where over to your left, you have a very, very, very narrow slit that's open versus a wide open Van Herrick over to the right. Now this is a UBM that you always want to look where scleral spur is, and then you can kind of determine the iris insertion from there. So let me do that again. This is an open angle, obviously, and this is where you have more convex structure, and you can just picture what's going to happen if you just do a laser iridotomy right over here how that's going to allow um, the structure of the iris to relax. Dynamic gonioscopy is something that is super, super important. The reason why it's important is because you can have a situation where the angle looks closed. And if you just indent just a little tiny bit, I don't mean pushing on the cornea a lot, but if you just indent just a little tiny drop, you can see that all of a sudden the iris bursts open. And that is a patient that is going to respond very, very well to a laser iridotomy. That means that they have iridotrabecular contact. You look around, see if there's been chronic angle closure where they've started to develop synechiae, or not, and you want to look carefully at all the different structures from that. But in terms of knowing whether or not this is a good candidate for something like laser iridotomy, having that indentation is a really, really good technique. We often write down after you indents easily, difficult indents, moderate indents, and then in a plateau iris, obviously, when you try to indent that iris, it doesn't indent, it doesn't open up. So it kind of gives you an idea to think about other things going on. All right, in the pathophysiology of the angle closure, we talk about push mechanisms, we talk about pull mechanisms. When you think about pulling the angle closed, so you're thinking about forces anterior to the iris that are causing that to happen. So an obvious one is iridocorneal endothelial syndrome, neovascular glaucoma, when you get that sealing of the angle, that can even happen 360 degrees. That's pulling the angle closed. Uveitis, you get that buildup of inflammation that causes synechiae and closure. That's closing the angle from anterior to the iris. These are the kinds of things that you're thinking about as you're doing gonioscopy. And contrast that with the push mechanism. These are the things that you think about more frequently. Is pupillary block, is a plateau iris, is a lens-induced glaucoma, malignant glaucoma. These are all different forces coming posterior to the iris, pushing into the iris from behind, that's causing that angle to close. Primary angle closure glaucoma affects 25% of all glaucoma globally. You might think that that's not a lot, but it ain't rare if it's in your chair. 3/4 of that is in Asia. 3.1 million Chinese are blind from this kind of glaucoma, and 28 million people have primary angle closure suspicion. Talked about that definition in the beginning, and that means that they have that areas that they're closed off, but not over 180 degrees. Causes, we talked about that too. It could be lens, iris thickness, insertion, ciliary body location, degree of block. This is a depiction of what happens after you do a laser iridotomy in a patient who responds well to it, who's had closure beforehand. So you can see that in the top picture, you have this iridotrabecular contact. You do the laser iridotomy, and all of a sudden, the iris relaxes. And it doesn't happen in every case, and it doesn't happen dramatically in every case. So even after you do a laser iridotomy, I think I remember learning at some point that after you do a laser iridotomy, you can dilate that patient, no problem. Don't worry about anything. We still do gonioscopy on a lot of patients that have had laser iridotomy because they continue to stay narrow even after they've had a laser iridotomy. That can be because they're developing a cataract. The lens is pushing into the chamber, and so it's not that you're risk-free after you do laser iridotomy, but definitely the risk decreases quite substantially. So this is something that's important to think about, because gonioscopy is, at least so far, what I've discussed it as is recognizing angle closure, recognizing the dynamic forms of the angle, how it's closed. Is it synechial closed? Is it iridotrabecular contact? You'd indent. It's kind of a dynamic exam. Can this be replaced with things like ICAM, anterior segment OCT? In other words, things that we could maybe implement into a telemedicine model, or something you're not touching the patient, and you don't have to master this gonioscopy technique. And the results from the study are pretty astounding, that it actually showed that gonioscopy and ICAM had a lot of variability between different examiners, and that ASOCT was the better way off, at least in detecting a narrow angle. Now, the anterior seg OCT, unless you're doing it in dark illumination and light illumination, you don't really get that dynamic approach. So you don't get a good feel for what's going on in the angle. But just in terms of determining whether or not you have a narrow angle an anterior cygo CT is a fine way to do that. And especially in a post-COVID, or I wish it was a post-COVID, in a COVID world that we're living in right now, when you don't want to do these extra tests, we have substantially reduced the number of gonioscopies that we're doing on patients for really new patients or patients that absolutely need it. And otherwise, we're sending them for an anterior cygo CT. But obviously, no one's doing the laser iridotomy until they actually see the gonio themselves. For optometrists who work with ophthalmologists, this can result in a higher referral for narrow angles to be evaluated for laser iridotomy. I have, you'll be hearing from Gus Demarias. I send him a lot more patients to think about doing laser iridotomies now, because for some of them, I choose to skip the gonio step, or I'll just get the anterior cygo CT. And that's on the one hand. And on the other hand, after you get the anterior cygo CT, sometimes things do look more narrow when you're doing gonioscopy than when you actually image it. And these kinds of things are okay. This is all part of glaucoma care, is working in a team approach, and you can battle it out with each other and think about whether or not it's good for that patient. But definitely having those relationships is important if you want to manage these glaucoma patients. The ZAPS trial was a really important trial done to determine whether or not prophylactic laser iridotomy is beneficial in patients. And the results were not great, in the sense that they were informative that the laser iridotomy can be helpful, but not necessarily so much more helpful than just monitoring the patient. And it's really not clear cut at this point still whether or not peripheral laser iridotomy should be done in the suspects. So it's not recommended as a glaucoma screening measure, right? So when you have these trucks and different programs that go out to screen glaucoma patients, you're not saying, well, if somebody has, a narrow angle detected, that you automatically do a laser iridotomy. And these are things to think about. These studies are important to help guide our care. But treatment was found to be effective in preventing progression to primary angle closure. But there was a low incidence anyway of development of primary angle closure in both the treated and untreated eye. So people constantly throw out the ZAP trial as a reason to go ahead and do laser. Really go back and look at that study if this is something that you're involved with, because it's just not clear cut, and it wasn't over a long period of time. Primary angle closure disease preferred practice pattern. This is something important for people to know. This is the one that just came out January 2021, and these are the new definitions. I'm not going to go through all of them here, but they should be in the handout, or you can take a screenshot of this about what exactly we're defining primary angle closure and the appropriate follow-up that goes along with that. This is something that I wanted to bring up as well, that the consistency between optometrists and ophthalmologists is pretty good in this study, and that's something important for us to know, that once you do it and you start doing it, your ability to pick up these things definitely gets better. I would pause for questions, except that I learned that we're going to be doing questions in a chat form. So we'll address, if you have any questions right now, I'm kind of finished with the primary angle closure portion of the lecture. So if you have questions, just jot them down in the chat so that we can discuss it after this next portion. So now we're talking about secondary glaucoma. This is the more exciting one to me. It's not so exciting to pick up a narrow angle. It shouldn't be that difficult to pick up a narrow angle, either by von Herrick or doing gonioscopy or taking anterior cygo CT. Secondary glaucomas is really fun. That's because these are the things that can kind of get missed. These are things that you really have to be invested in the patient and be thinking about other things and thinking about processes and the pathophysiological ways that glaucoma develops. And you really break this down into unilateral and asymmetric glaucomas. Now, we know that primary open angle glaucoma is a diagnosis of the exclusion, right? So if you see glaucomatous type neuropathy or an optic neuropathy in one eye, or in both eyes, you don't just jump and say, oh, they have primary open angle glaucoma. That's when you think, okay, I have to go back and bring this patient back for gonioscopy, bring this patient back and look for other things, ask them about steroid use, ask them about if they're a runner, and they, think about if they're high myope, if you're looking for dispersion and things like that. So secondary glaucomas are where we can really differentiate ourselves in our glaucoma exam. This is a fantastic mnemonic. If you ever use this, please give credit to our former resident, Dan Gong, who's now at Harvard doing his second year in his retina fellowship. He's really just a superstar, but he came up with this when he was at Columbia, vitamin C and D. This talks about all the different categories that you can have of a unilateral process. And we'll go through each one of them with some pictures now. So when you're talking about a vascular glaucoma, we think about Sturge-Weber, we think about a fistula, we think about any kind of venous obstructive disease, neovascularization. So if a patient has had a branch retinal vein occlusion or central retinal vein occlusion, you're always looking for vascularization. This can be so subtle. So subtle. If you have a patient who has an occlusion, a history of having an occlusion, and they have an elevated pressure, you really want to look so carefully at the iris and the angle, because these patients can have very, very subtle neovascularization. So you always want to be looking for that. Here's an example of a patient with a fistula. So you see obviously tortuosity of the vessels, and then when you look, you can see the blood in Schlemm's canal. And you don't just assume that you've been pushing too hard on the gonio, and so you have 360 degrees of blood in Schlemm's canal. You think about other things. And in this case, it's a fistula. Iatrogenic, this is a great area. This is a really great area because a lot of patients have things done to their eyes. A lot of patients have had trauma. A lot of patients have had different kinds of surgeries, or been on different types of autoimmune type of steroid treatments. And these are things that, this is why the medical history becomes very important. The surgical history becomes really important, especially when you're seeing these patients 30 years out, 10 years out, whenever it is after they've had some event in their eyes and you're seeing these patients. These are things you want to think about, especially if they're developing glaucoma. Now, this hopefully, most of us don't see malignant glaucoma, but this is an example of a patient who might have already had a laser iridotomy, because malignant glaucoma we know happens in more narrow angle patients. They've had a laser iridotomy, and then later down the line, they can develop this aqueous misdirection glaucoma. And you want to be looking out for different things on the gonioscopy. So you can see in the picture on the left how narrow that chamber is. Look carefully, because this may look like a deep anterior chamber initially, but look at the conical beam that's directed over the anterior chamber and see that slit between the cornea and the anterior chamber. There's almost nothing there. Okay, so this chamber is almost collapsed. And when you put a gonio lens on, right, you're not going to fix that by doing indentation gonioscopy. This is somebody that needs an urgent referral. Traumatic angle recession is a really common one that you can see. This is something that you're going to miss very frequently if you don't do gonioscopy 360 degrees. So during the technique, and you're putting the gonio on the lens, you're looking at obviously the superior, inferior, nasal, and horizontal. I remember that we learned this back in the day from Dr. Duell. He said, if you don't rotate that lens, you're going to miss half angle because your missers. And that's true for patients like angle recession. You will miss these things, and it looks like a deep, wide open angle. I wanted to show you that one because this is what we see most commonly. So this is a really fuzzy picture, but the reason I chose to use it is because this is pretty classic of what you'll see when you get used to doing gonioscopy. It's not going to be perfect. It's not like everybody else who's doing gonio gets a clear, perfect image each time. It's just that the more that you do it, you can pick up and see, oh, that looks like it's an angle recession. Even though the picture is a little fuzzy or your image is a little fuzzy when you're doing it, these are things that you can learn to pick up over time. So you can see, if I can move my mouse, you get that wide open ciliary body over here. And when you circle the lens around and you can see the different quadrants, you realize that it's much wider in that quadrant than the rest of the angle. An autoimmune metabolic inflammatory type syndrome, so you get UGG syndrome, uveitis, Posner-Schlossman, herpetic Fuchs. The herpetic Fuchs, UGG syndrome, those are obviously the more rare, but uveitis, we've all seen patients with uveitis. That angle needs to be checked at least once to see if there was any damage done in the angle, to see posterior anterior synechiae, and think about what would a sticky iris look like. So this is a fun case to show just because the pictures are great, with a Fuchs or was initially diagnosed as a Fuchs heterochromic iridocyclitis. So you can see all the different, you can see on the cornea, you have the little white lesions, and then this patient had a uveitis associated with this. And then when you do the gonioscopy, you can see the tortuosity of the vessels and see neovascularization. And this patient ultimately had sarcoidosis, but this was a patient actually seen at the University of Iowa. And sarcoidosis is known as a masquerader, and it masqueraded as this one. But interesting pictures to pick up in gonioscopy. Neoplastic. This is something that you don't want to miss. I think it's fair to say that I wouldn't say that they're rare. I think that they happen with enough frequency that if you see a patient with an iris cyst, you want to make sure that you do gonioscopy, or at least send them to someone who can do it and has a UBM or works with an ocular oncologist. These are patients that you don't just want to say, come back in a year. Obviously, ciliary body tumors are going to be more difficult to pick up than an iris cyst or other kinds of things, but let me show you an example of a patient with iris cyst. So I bet that if I asked for a show of hands, most people would say that they've seen patients with iris cysts. This happens enough that it's, this is nothing that's new. But remember that even though you see these frequently, you still want to make sure that it's just a cyst, and we're not the ones to necessarily decide that. So you do the gonioscopy. If you see that there's elevation, you send that patient out to make sure that nothing else is going on. I've seen maybe 5 that I can think of these in the last year, but they happen enough where it's not rare, but it's something that you want to get checked out. Okay, congenital anterior segment dysgenesis syndrome. So these are the ones, obviously miss these. Peter syndrome, aniridia, Axenfeld, aphakic glaucoma, in syndrome, you can see all different kinds of anomalies. The reason I chose this one is because this is something that maybe you would have missed. There's nothing dramatic. If I ask for a show of hands of what's wrong with the picture, I don't know what, I bet that we'd get a wide range of responses, but you can see the pupils a little ectopic. You can see the iris color, it may be a little faded in certain places. And then when you do gonioscopy, you can see the synechiae and embryotoxin. Ice syndrome, these are all unilaterals. This is the first one that people jump to when they say, unilateral glaucoma. They think about the ice syndrome. You can think about just primary angle closure and nevus of Ota. This is another ice syndrome patient who, again, isn't necessarily very dramatic. We had a patient who presented to us at this point, maybe 3 years ago, 2 years ago. She came in for a general exam. I was there that day, and Jason Harwitz, one of our retinal specialists, was there that day. He was on her schedule because she came in for a she had been seeing rainbows and halos in her vision. Her vision was 20/20 uncorrected. And then the technician literally came running down the hall to me saying, her pressure's 50, her pressure's 50. And obviously, you don't want to alarm anybody. You go into the room. These are things that we see pretty frequently. And check the pressure again, it was 50. And the first thing that I did was gonioscopy, and her angle was wide open, absolutely wide open. I looked very carefully for cells. There were no cells. And we immediately sent this patient urgently to the glaucoma clinic and started her on topical hypotensives. This patient also was 6 weeks pregnant. And it was a really interesting patient who ultimately did not have ice, although that was highest on the differential. And they look at really fantastic technologies that are available to look at the corneal endothelium now. We think about looking at the corneal endothelium for cell count, for different kinds of diseases, but they look also for ice factors. And this patient did not ultimately have ice, and she had she was a bit of an anomaly that needed multiple surgeries. She had no history of anything. A really interesting patient. Lens induced. So this is a really easy one to think about, that push mechanism. So you can think of that lens pushing forward into the iris, that's pushing the anterior chamber to be much more narrow. Here's an example of the phacomorphic glaucoma. So you can see again, here's a patient who's had a laser iridotomy, presents with very, very narrow angle and very narrow anterior chamber. I do encourage you to look at the anterior chamber itself, not just the temporal and nasal portions when you're doing an exam, because you also want to see shallowing of the anterior chamber if the angle is open. You want to see how narrow kind of the whole area is, because in phacomorphic glaucoma and things like that, it's obviously much more narrow chamber, much more shallow chamber. So this is not someone that you're just going to dilate. And when you do gonioscopy, you can literally see where the lens is, right? In the right picture, you can see that lens is pushing into the iris, making it very, very much bowed. And you can also imagine that if you would try to indent this patient, you would, again, by show of hands, you would not expect to see this indent very easily. So an easy way to tell whether it's narrow from light iridotrabecular contact and light pupillary block as opposed to something pushing and posteriorly. Asymmetric process, these are things that are really, really common. Pigmentary dispersion syndrome and pseudoexfoliation syndrome. These are things you don't want to miss. Patients come in very frequently with, the diagnosis of open angle glaucoma. And, if you take an extra second and you transilluminate the iris and you look for these other things on gonioscopy, you will find these patients. Betsy, I think that there's some, this is not me drawing on the screen. Let's just make sure that stops. If you can help me out with that. I don't know what the blue lines are coming from. So in pigmentary dispersion syndrome, in my opinion, this is where we matter in optometry. This is what we can pick up very easily. A lot of the other unilaterals and things, those are things you'll probably see that something's wrong. You won't necessarily see what's going on in the angle. You're going to be referring for, further evaluation. These are things we can find pretty easily ourselves. And once you find a pigmentary patient, those patients can progress rapidly. They can have high spikes. They're much more frequent retinal events, so retinal tears, retinal detachments, because they have that high myopia association. Even if they don't have that high myopia association, they can be at higher risk of having retinal breaks. So with this, going back to our documentation. So let's do this example. So this is your gonio picture. What do you write down? Well, the iris is inserted at the ciliary body. I'm sorry about that. The approach is concave. There's uniform pigmentation and it's very, very dense right here. And then you can even see the Sampalesi's line up above it. So you have this dense uniform pigmentation and then a splotchy pigmentation above it. Those are also important things to document because normally you think of Sampalesi's line and splotchy pigment as exfoliation syndrome. But when you see this and you document both, you go back and you look again at the approach of the angle because only really in pigmentary, you're going to have that wide concave approach. And then when you transilluminate the iris, you go back and you see these transillumination defects. And there you go, you have your diagnosis of pigmentary dispersion syndrome, and especially when you look at the cornea, you can see Kirkenberg spindle. Pseudoexfoliation syndrome, this is also a patient that you don't want to miss. Also asymmetric process, not unilateral, although it often starts in one eye. Generally, you get it in both. You're looking for the material, the exfoliative material. You're looking for splotchy pigment, that Sampalesi's line. And again, these are things that we can pick up easily in our clinics. These are kind of the slam dunks that you look, you kind of see they have that pupillary rough atrophy. You maybe see a little cell in the anterior chamber. You're not sure if it's cell or something else. And you go and you put a gonio lens and whammo, you can see the splotchy pigment. This is someone with exfoliation syndrome. And these patients also need very careful management. They're not just open angle glaucoma patients, but people who can spike, people who can have much more progression of their glaucoma more rapidly. So what do you think? Is gonioscopy here to stay or not? This is an interesting piece I just came across that Ben Casella always writes pretty good, really good stuff. And he wrote something, gonioscopy and imaging work in tandem, talked about how gonioscopy probably is here to stay in terms of ruling these other things out, but that The anterior sagittal CT and other things can definitely work in tandem with it. And then there are other things that are going to come out. You know, there's telemedicine is definitely on the rise. There's automatic pigmentation grading scales now for trabecular mesh work in gonioscopic images. And these are things that we're going to have to think about as practitioners. Again, going back to the drawing board, why do we do gonioscopy and how can we substitute gonioscopy in our exams? Back to our cases. So I'm going to skip through these because if you want to discuss these, to talk about more management, definitely reach out with some questions in the chat. But you have this patient, this is obviously the first thing on your mind is acute ankle closure. And so I'm going to be, you know, out in the exam room getting Gus over from next door. But first I'm doing gonioscopy. I'm doing dynamic gonioscopy, pushing, trying to get that angle open a little bit. I'm giving them what we call the works. I'm putting latanoprost in, I'm putting in vermonidine, I'm putting in whatever we have in, you know, in the exam room, Repressa, and just trying to lower that pressure until we can get them set up for a laser iridotomy. Case number 2, this is someone who has no symptoms. This is not an acute attack. You obviously want to do gonioscopy and see if there's something obstructing the angle, see if they have cells, see if they have something going on. And then the very next thing that you're doing is you're lowering that pressure with the works. Case number 3, this is what I was alluding to, high myope, prescription change, no symptoms, grandfather as glaucoma. These are the patients you want to look so carefully for pigmentary dispersion syndrome. So careful. Young male comes in as a high myope and with a family history of glaucoma, that's what you're thinking. So you do that gonioscopy, you can see that wide open angle, concave approach, and the other things that we discussed. This is something actually that happens more frequently than we would like, is, you know, a hyperope who comes in with very narrow angles. If you are not 100% sure that that angle is open and they don't have a clear retinal detachment, it is not necessarily, I'm going to be careful how I say this, but it is, you don't want to put that patient into an attack, right? Because that would cause worse, a worse result for her than if you dilate and you say, oh, you know, you have a PVT, or if she has a retinal tear and it just started, you know, this has been going on for 3 weeks. There's obviously no acute event of a detachment if she's still seeing 20/20. This is something you're going to be consulting immediately with glaucoma and retina. When I see these patients who come in with a no sign of a retinal detachment, you can look at the posterior pole, you can check the pressure, you do gonio. If you have a closed angle, I have them see glaucoma that day or the next day, and then follow up with retina a day or 2 later. So this is someone that just because they have a new floater does not mean immediately dilate. It means you can look, you can get an optos. If nothing is going on, you can have them see glaucoma the next day and then retina the following day. But this is someone that you're obviously going to be communicating about right away after the exam. Thank you to our my chairman and vice chairman who have taught me quite a bit about gonioscopy. And I will now take questions.
Thank you, Shira. That was great. Really, what a review of Gonio. So we have, if anybody has a question, feel free, please type it in now. If not, we will move on. Shira, gonioscopy is, like a lot of things, a learned skill, as you talked about, that people just need to do. And part of it is just that I guess many optometrists never became comfortable with it while they're in school. You almost have to make somebody make you do it to start to learn to do it. Any comments just in getting people to be comfortable?
Yeah, I think it is I've spoken to a number of people who tell me that they, that it's something that they're not comfortable with. And like anything else, by practicing is when you become comfortable. I remember Dr. Madonna saying in school, if you want to be good at gonioscopy, you do it on every single patient. And I took him up on that in clinic. And I still remember the first day that I did it with an intern who was with me. And I was obviously a 3rd year, so I was supposed to know a lot more then the second year scribe who was with me, and obviously I didn't, but I did the gonio, and I said, oh, open. And then Dr. Madonna comes in, he's like, oh, that's a great patient. We should put that patient up on the camera. Pulls the patient out, puts them in an exam room, puts on the camera. He's like, see that large area of synechiae right here at 270 degrees? And, I felt pretty silly, but it taught me that I said in that area, I looked at my diagram, I said it was open and it had IPs, and so from that, I learned what synechiae looked like over IPs. So I think there's a couple of things to do. Number one is you have to be willing to try it. Number two is you have to be willing to ask questions and get a mentor or join a Facebook group or look at YouTube. There's lots of different ways to do it, but it can definitely set somebody apart in their glaucoma exam.
Okay. So Shira, we have one question here and then we'll move on. The question is, does rubeosis always come through the pupil?
That's a good question. Before I say yes, let me think for a second. Yeah, I definitely, I cannot recall a single time seeing otherwise. I know that I've learned that it always comes through the pupil, and I don't recall seeing anything to suggest otherwise. Because obviously, the sequence of events that happen with neovascularization is you have some event in the retina, right? That causes hypoxia, that causes ischemia, and so you have new blood vessels that are growing in the retina, and that then will come anterior in the eye, and it will start at the border of the pupil, and then it will make its way through to the angle. There was one patient that I saw with Dr. Chaffee who had a branch retinal vein occlusion a couple years earlier. And when he came in, he didn't have an elevated pressure, but there was something funny about his pupillary border. It wasn't red, it was almost pigmented, but he looked at the posterior pole and it looked like he had some kind of reactivation of maybe neovascularization, or there was something going on with that patient that wasn't very obvious. And we had our retinal specialist went ahead and did an injection in that patient. And that was really picked up initially from looking at the pupillary border. But to answer your question, at least in my experience and from what I've read and what I've seen, it always does come through the pupil. Good question.
Okay.
Does anterior segment OCT measure one specific quadrant?
Yeah.
Do you want me to answer that or
go ahead. There's another one, and then we just need to move on. But why don't you touch those? Sure.
Sure. Anterior segment OCT, and we do a lot of it now. Its default is to measure horizontal quadrants. So it measures the 3 o'clock and the 9 o'clock. But if you have a good imager, you can get other quadrants too. So if you think that you see a cyst in a specific quadrant, you can try to measure it right through. But the default is 3 and 9 o'clock. Also a good question.
Yeah. So saying that, so when I assume when they talk about anterior OCT, they're referring to using a Cirrus or their OCT that has the and just use it like that. But there are a series of swept source anterior segment OCT devices that have hit the market in Europe and in Asia and about to hit it in the United States. This is the Interion. NIDEC has one that will allow, that allows. NIDEC has a gonioscopy device that will allow really gonioscopy to be performed, because one of the mistakes people make is the impression that an anterior segment OCT can replace gonioscopy. And I think, from what, really can't. So here, one last question, and I'm going to move on unless Shira, I've heard that inducing an angle closure with dilation is very, very rare, even in someone with a narrow angle. Your thoughts?
Two thoughts. Number one, yes, I do think that it is rare. However, we all know it ain't rare if it's in your chair. And we've probably all either seen it that one patient that we remember or heard about, you don't want to be the one doing it. And our first priority is to the patient. And you want to make sure that you're not dilating a patient who may go into an attack. So if there's any concern that that is the patient that will go into an attack, just don't do it. Yeah, that's what I would say. And read the ZAP trial. The ZAP trial looked at this really, really well, and it is rare, but you don't want it to happen to you.
Yeah, I mean, and one of the challenges is that if it does occur, it doesn't occur. Many optometrists are under the impression that they can do a post dilation IOP, and that'll give them an idea if somebody did close, and that's not how angle closure works. If you remember back to your school, it closes when the pupil is coming back down, and that's often several hours after you've dropped them. So unless you're having them sit around for another couple of hours, you get a false sense of security if their IOP hasn't risen an hour, 45 minutes, an hour after you've dilated them. But with that, Shira, thank you very much.